Good evening, everyone. How are you all? All right, so welcome to First Aid AMC MCQ Cardiology Lecture 2. So we are going to start with this theory session, right? So I hope that you guys enjoyed our session so far. We had a couple of free sessions already done. And among them, we had our psychiatry trial class on 24th of June. Then we had one class on tips and tricks to solve questions. And then we had our cardiology class 1. And tonight we are going to do the cardiology class 2. And unfortunately, there will be back-to-back classes. So today there is one class. Tomorrow we are going to have our cardiology question solve class. And then on Wednesday, 15th of July, you will also get a class for recent question solvation with Dr. Rabia. So that will be your free 2-week sessions, all the 2 weeks classes. Okay, so let's start with cardiology 2. Before we start, let's just have a look at this video to understand our today's topic. Our first topic will be congestive cardiac failure. Okay.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Okay, so that's actually a little bit idea about the heart failure. So let's start congestive cardiac failure. Now, before I start, remember the previous session that how the basic cardiology works. That means what is the pathophysiology of cardiology or congestive cardiac failure. So we remember that if this is our heart, obviously we know that our heart has 4 chambers like this, and obviously blood will come from here and here. So from superior vena cava, inferior vena cava, blood will go to your right atrium, then go to the right ventricle, then it is supposed to go to your lungs through the pulmonary artery. And then it will go to the lungs, it will become oxygenated, and then come back to the left atrium by pulmonary vein. And then from left atrium, it will go to the left ventricle, and then through aorta, it will go to your whole body. So that's how it works. Now, heart has 2 basic functions. One is called systole and another is diastole. Systole means that when heart actually squeezes itself or contracts to pump the blood out of the heart to your body, that's what we call as systole. And diastole means when heart actually relaxes itself to receive all the blood from your upper and lower extremity. So there are 2 kinds of heart failure in that way. If systolic or heart contraction is not good, that is systolic heart failure. If heart is having problem with relaxation, that's what we call as diastolic heart failure. Then there is 2 other kind of heart failure, right heart failure, left heart failure. So if the left heart is not working, what usually should happen? So let's say that the left ventricle, it's not working properly. So that means the blood is not going through the aorta into your body. So there is accumulation of blood in the left ventricle, now it's giving back pressure to left aorta. Now, at one point of time, left aorta will become overwhelmed or oversaturated, right? Then it will start giving more backward pressure to your lungs. So when lungs will get this back pressure, then fluid will start accumulating in the lung tissue. And that is what we call as pulmonary edema due to left ventricular failure. Okay? At one stage, what will happen that let's say this is the lungs and that's the heart and that's the pulmonary artery, right? At one stage, what will happen? Lungs will become overwhelmed as well, or there will be a lot of fluid accumulation over there. Then it will give more backward pressure to the pulmonary artery. And when there is pulmonary artery pressure increases, what we call them? We call them pulmonary artery hypertension, PAH. Now, if there is hypertension or increased blood in the pulmonary artery, what will happen to the right heart? Now, right heart needs to work more efficiently or more harder to push the blood from the right ventricle to the pulmonary artery, because now there is more pressure in the pulmonary artery. So right heart will now work more harder to pump the blood. At one point in time, there will be right ventricular hypertrophy because the muscle will work a lot and muscle become hypertrophied. And at one point in time, then this right heart will also fail. And then what it will happen? Patient will develop right heart failure. When there is right heart failure, then right atrium will become oversaturated. Then what will happen? The superior vena cava, from where the upper extremity fluid was coming, now there will be back pressure on that. So you will get a increased jugular pressure, or JVP will be raised. There will be accumulation of fluid in your lower leg because the inferior vena cava, which was carrying your blood from extremities, it can't do that anymore because this heart is already full with blood. So because of that, patient will develop ascites, patient will develop hepatic congestion, which will cause tender hepatomegaly, and also later on, patient will develop leg edema. And that is what we will call as congestive cardiac failure. Okay? So see the pathophysiology, it's very straight cut. If you understand it, there is no memorizing in here. It's all happens according to the math, according to the pathophysiology of your heart. Is this understandable, guys? Did you get it, that what I said? Yes, good. So that's about your cardiac failure. Now let's move on. A 60-year-old a 60-year-old man presents to his primary care physician for several months of dyspnea on exertion, exercise intolerance, and lower extremity swelling. He has a past medical history of sarcoidosis. On physical exam, he has raised JVP, pitting edema in the lower extremities, and an echocardiogram shows an ejection fraction of 35%. So that's your one of the heart failure question. So what you have got in here, patient having shortness of breath on exertion, patient having lower extremity swelling, which is the pitting edema in the ankle, and raised JVP. Have a look at these two cases and think that which one is systolic heart failure and which one is diastolic heart failure. So you have got this patient, 62-year-old with hypertension, dyslipidemia, present with dyspnea and lower extremity edema for 2 months. Raised JVP, S3 gallop rhythm, apical impulse is displaced. Chest X-ray showed an enlarged cardiac silhouette, and echo shows a dilated left ventricle with an ejection fraction of 35%. So what do you think this patient has got, systolic or diastolic heart failure? How we know? Your ejection fraction is the measure of cardiac output. So if cardiac output is low, what does it mean? It means that heart is not having enough systole, or heart is not having enough contraction, right? So if heart is not enough contraction, then obviously cardiac output will be low. And if cardiac output is low, ejection fraction will be low. What is the normal ejection fraction? Usually more than 45%. So this patient obviously has got a reduced ejection fraction as well. So if you see reduced ejection fraction in echocardiogram, that confirms that it is a systolic heart failure. And according to the symptom, do you think it's a right heart failure or left heart failure? Most likely it's a right heart failure, okay, because they haven't said anything about the lung gauges, like no bibasilar crepitation. If there was a bibasilar crepitation, most likely it would be a left heart failure. But because there is raised JPP, because there is ankle edema, most likely it's a right heart failure. And maybe that's some left heart is also strained, but they haven't said anything about it here. So a 57-year-old man with a history of multiple myeloma presents with dyspnea and lower extremity edema. There is raised JVP, audible S4, apical impulse is non-displaced, chest X-ray shows normal cardiac silhouette, which means this patient has not got any cardiac enlargement. Echo shows a thickened left ventricle with an ejection fraction of 65%. So that's your diastolic heart failure, obviously. In diastolic heart failure, patient's cardiac output or ejection fraction will be usually will be normal. So that's a normal ejection fraction for this patient, because in this case, your heart also does not get enlarged like systolic heart failure. So you will get a normal cardiac silhouette on chest X-ray. Because if cardiac enlargement is not there, obviously apical impulse will not be displaced as well. Okay, so that's how about we know about diastolic heart failure. Now let's move on to symptoms a little bit. We'll come to the management later on, but let's go to the symptom. So because patient with congestive cardiac failure, they get fluid accumulated almost everywhere in the body. They present to you with dyspnea on exertion, and most importantly, orthopnea, which means when they lie down in bed, they get more difficulty in breathing. So they say that, doctor, I need to use more than 2 pillows at night. And sometimes it can also give a irritating cough, especially at night time. Patient will have weight gain because of edema. Pitting edema or ankle edema will be there. Abdominal discomfort can be there because of hepatic congestion and ascites. Patient, because of poor cardiac output, they can also feel dizzy and very weak. What are the specific features of right and left heart failure? For right heart failure, we already know there will be elevated JVP, there will be peripheral or ankle edema, and then there will be tender hepatomegaly. These three are the main feature of right heart failure. For left heart failure, you mainly get bibasilar crepitation in the lung. You can get S3 gallop rhythm. You can also get kind of tachycardia, tachypnea, those kind of features. But bibasilar crepitation is usually the main feature of left heart failure. What are the physical findings we get in heart failure patient? Obviously, pulmonary vein, which is your crepitation, peripheral edema, ascites, hepatomegaly, raised JVP. And if it is a systolic heart failure, we can also get a displaced apical impulse. Okay. So third heart sound, which means the S3 gallop rhythm, it's also a very important finding for left heart failure. Now we already know this congestive cardiac failure, systolic and diastolic one. If you want to give it a go, let's just watch the video a little bit.
Heart failure occurs when the heart is unable to provide sufficient blood to meet the body's needs. Heart failure is not a disease on its own, but rather a consequence of other underlying conditions. The impairment of the heart function can be due to an inability to pump effectively during systole, called systolic heart failure, or inability to fill properly during diastole, called diastolic heart failure. Heart failure can be right-sided or left-sided, depending on the side that is affected. About 2/3 of all left-sided heart failures are caused by systolic dysfunction. In systolic heart failure, ventricular contraction is compromised. This may be caused by any condition that weakens the heart muscle or creates more difficulty for the ventricle to pump. The most common include coronary artery disease and its consequences. Plaque buildup narrows the coronary artery, reducing blood supply to the heart muscle. Complete blockage can cause heart attacks, which often leave behind non-functional scar tissue. Dilated cardiomyopathy. The ventricular wall is dilated, becomes thin and weak. Hypertension. Higher systemic pressure makes it harder for the ventricle to eject blood. This is because the pressure in the left ventricle must exceed the systemic pressure for the aortic valve to open. Valvular heart disease. Damage to the valves, such as stenosis, also makes it more difficult for the ventricle to pump. The effectiveness of ventricular contraction is measured by the ejection fraction. Typically, the left ventricle is filled with about 100 milliliters of blood, but only 60 milliliters is ejected during contraction. This corresponds to an ejection fraction of 60%. The normal range of the ejection fraction is between 50 and 70%. When ventricular contraction is impaired, the volume of ejected blood is reduced, and so is the value of the ejection fraction. In systolic heart failure, it drops below 40%. In diastolic heart failure, the ventricle is filled with less blood. This may be because it is smaller than usual, or it has lost the ability to relax. The ejection fraction may be normal, but the blood output is reduced. The ejection fraction is therefore commonly used to differentiate between systolic.
Okay, so that's actually a bit about your systolic and diastolic heart failure. You can go through the video again if you want. Let's move on. Okay, so we already know what is the difference between a systolic heart failure and diastolic heart failure. Now, what are the causes of systolic heart failure? Systolic heart failure can be done by prior ischemic heart disease, previous myocardial infarction, and obviously, if someone has got hypertension, that can also cause it. Diastolic heart failure can be caused by obesity, hypertension, diabetes, and also ischemic heart disease, hypertension, aortic stenosis. This can also cause it. Not very important to remember. Now, come to the main thing. If you get a patient who present to you with a features of heart failure, what is your next most appropriate investigation, guys? So a patient coming to you with all the features of heart failure, what is your next most appropriate investigation? Anyone? Yes, ECG, right? The next most appropriate means initial. So what we do initially, we don't do cardiac enzyme before doing ECG, right? So first thing that you do is do a ECG first. Now, I know that sometimes we know everything, but when it comes to the question, we just forget the simple thing. Like doing a ECG is very important, but we just forget it because we think about more complicated thing in the exam. But sometimes in exam, they just want to know the basic stuff. And you don't want to miss that because those questions, if you miss, the software will treat you like that you don't know anything. So these are actually very important that you don't miss this thing. So first do the ECG. You can also do cardiac enzyme later on if you think. If they ask you what is the most appropriate investigation, the most appropriate means definitive. So definitive is always echocardiogram. Yeah, very good, Dr. Savita. So echo is the most appropriate or best investigation, and next most or initial investigation is always ECG. Echocardiogram will give you the idea that what is the cause of the problem, and also you will get an idea that is it a systolic or diastolic heart failure. You can do chest X-ray if you want, but it's not actually important part of investigation. If sometimes in the question they ask you that so a patient is already diagnosed with heart failure and you want to monitor the progress of this patient. Is there any test that you can remember which you can use to monitor the progress of heart failure? So that's called BNP. So brain natriuretic peptide, BNP is the test that we do to see the progression of, or we started treatment, ejection fraction at that time was, let's say 30%. Now we started treatment, we want to see that how the treatment is affecting the heart now by doing the BNP. Okay, but BNP, it is not confirmatory or diagnostic investigation for heart failure. We just do it to check the progress of heart failure. Remember that. Now come to the management of heart failure. If you get a patient with a systolic heart failure, then your first line medication is ACE inhibitor or ARB. If ACE inhibitor does not work, then you will add medication accordingly. So with ACE inhibitor, if patient has got congestion like fluid accumulation in the body, start furosemide 40 to 80 milligram BD. Plus, if furosemide does not work, even after giving 80 milligram BD, there is no improvement, then you go for spironolactone 12.5 daily. Now you don't need to remember the dose. So just remember the name of the medication. So ACE inhibitor doesn't work, then the next one is furosemide. Doesn't work, next one is spironolactone. If that doesn't help, then you can add a selective beta blocker like atenolol, metoprolol. But we only add beta blocker when patient is having a stable congestive cardiac failure. Okay, if patient is congested or having a decompensated heart failure, that means that patient having fluid accumulation, breathlessness. If that is the case, then you will not start beta blocker because it can cause worsening of the heart failure. But when patient becomes a little stable, then you can start the selective beta blocker. And the last option would be digoxin. Digoxin is not our first choice anymore because of its lot of side effect, but that is actually the last option that you can try. So ACE inhibitor, furosemide, spironolactone, beta blocker, digoxin. That's the stepwise approach for systolic heart failure. Now, in the question, sometimes they can ask you, among all the medication, which usually has some mortality benefit. So along with the ACE inhibitor, beta blocker also have mortality benefit in a heart failure patient. Okay, so ACE inhibitor and beta blocker, these two has some mortality benefit in a heart failure patient. So this is a must that you have to add these two medication. But beta blocker, only we give it when patient is stable. Moving on to diastolic heart failure. Diastolic heart failure, the management is based on mainly treating the underlying cause. If patient having hypertension, manage the hypertension. So if patient having diabetes, control the diabetes. But the basic treatment is with calcium channel blocker and beta blocker. Why so? Because what is the problem with diastolic heart failure? It's not relaxing enough, which means that it's pumping more than usual. So if you can give something to relax the heart down, that's going to do the trick, right? So what can reduce the heart contraction? So something which can reduce the heartbeat or heart rate. So what we have got to reduce heart rate? We have got calcium channel blocker, which is the rate limiting one, like verapamil or diltiazem, or we have also got beta blocker. So these are the two medications that we normally give for diastolic heart failure. We normally try to avoid diuretics because patient already not having enough blood to come into the heart. If you give diuretics, patient will lose more blood volume, which can make it more worse. So these patients in diastolic heart failure, they are not very congested, okay, like systolic heart failure patient. So we don't need to go for too much diuretics, except if they are having congestion or having too much fluid accumulation, then only we can go for it. Okay, so in the question, if they ask that patient has got ejection fraction of 60%, then we know it's a diastolic heart failure. And then we would give either calcium channel blocker or beta blocker as a first line treatment. So what are the medications that we have got to improve survival in congestive cardiac failure? We have got ACE inhibitor, beta blocker, and spironolactone. So these are the three medications which can improve survival in a congestive cardiac failure patient. So these questions come in the exam, so please remember it. So that's all about your heart failure. Just a little bit idea about some of the medication that we use. So the common medications which we use in heart failure are diuretics. So we have got thiazide diuretics, we have got loop diuretics, and potassium sparing diuretics. Now this is important because in exam you will get a lot of side effect related question, and usually the common medication side effect. So we all know thiazide diuretics. It is a common medication that we give to treat hypertension. So the complication that you can get from thiazide is that it can cause almost every electrolyte imbalance. So you can get low sodium, low potassium, but you can get high calcium and high uric acid. If a patient has got high uric acid, what they are more prone to? Guys, is there any condition which can happen if someone has got increased uric acid in their body? Gout, very good, Dr. Benish. So yes, so you can't give thiazide diuretics in a patient who has got a diagnosed gout. It can also cause blood-related problem like agranulocytosis. It can also cause glucose intolerance, which means a diabetic patient should not be given thiazide diuretics. So these are the important complications of thiazide. Indapamide also act similar like thiazide diuretics, and the complications are pretty same. Loop diuretics like furosemide. Furosemide is usually used in heart failure patient, It can cause low sodium, low potassium, low calcium. It can cause ototoxicity, that means hearing issue, and it can cause interstitial nephritis. So these two are very important complications. Like if a patient has got hearing problem, we would not go for furosemide in that patient. Then we have got potassium sparing diuretic, which is our spironolactone. This can cause hyperkalemia and gynecomastia. Remember one thing, that you should not, when you give ACE inhibitor and spironolactone to a patient, there is a high chance that that patient can develop hyperkalemia, because ACE inhibitor itself causes high potassium, and also spironolactone causes hyperkalemia. So if you give both ACE inhibitor and spironolactone in a patient, you have to monitor their potassium. And always remember that spironolactone is one of the most common cause of gynecomastia in a patient. Next, digoxin. So digoxin is also important for a severe heart failure, especially if you have tried every possible medication, but still patient symptom is there, the last digoxin. Digoxin usually work by inhibiting the sodium-potassium pump. Now, if sodium-potassium pump is not working properly, what will happen? So let's say this is your one cell, and that's your sodium-potassium pump. Normally, sodium should go out and potassium should go in. Okay? So sodium will go out of the cell and potassium into the cell. When this pump is not active, then what will happen? There will be more sodium inside the cell. So increased intracellular sodium will be there. Now, what usually should happen? When sodium comes outside of the cell, then calcium goes in. All right. Now, when sodium stays inside, calcium stays inside as well. The problem, the basic thing is that the pump does not work. Now there is more sodium inside. That means that sodium will also attract more calcium inside the cell. So there is more calcium inside your cell now. When there is more calcium inside the cell, or intracellular concentration of calcium is high, it causes increased cardiac contractility. So now your heart will beat faster than usual. Okay, so that's how the digoxin usually works. So it acts as a pump. It gives pumping action to your heart so that it beats faster. Now the problem with giving digoxin is that sometimes it has competition with potassium. So both digoxin and potassium, they compete each other to enter into the cell. So they have actually similar receptor to take into the cell. So what happens that if you have more digoxin in your body, all right, now let's say you have more digoxin in your body. So then what will happen? Digoxin can easily compete with potassium, get attached to the receptor and go into the cell. And sometimes it can cause digoxin toxicity also, because now more digoxin is going inside the cell. The other issue that somehow on the opposite side, if you see that if potassium is low, so if you have got hypokalemia, then what will happen? Digoxin already wins. So then digoxin again will go more than potassium, and that can cause toxicity. So hypokalemia causes digoxin toxicity. Now, if it happens opposite, like potassium is higher than digoxin. So if a patient has got hyperkalemia, then it will decrease the digoxin activity. So digoxin activity will be decreased at that time. Okay. So that's actually the relationship between digoxin and potassium. So if a patient has got hypokalemia, that might be the reason why this patient has got digoxin toxicity. So remember this line because it comes in exam. What are the side effect or toxic effect of digitalis or digoxin? The most common side effect is nausea and vomiting. It can give gynecomastia, blurring of vision, yellow halos around the object, and it can give you almost every arrhythmia that you can think about. But most commonly, it gives paroxysmal atrial tachycardia and premature ventricular complex. These are the most common arrhythmia given by cardiac digoxin toxicity. If you have got a patient who is showing these features of digoxin toxicity, or there is ECG finding of digoxin toxicity, the first thing that you do is to stop the digoxin. And you can check the digoxin level in their blood, but sometimes even it can be normal while patient actually got toxicity. So digoxin level does not show actual toxicity sometimes in your blood. Let's say even after stopping the drug, patient is still not well. Then there is a antidote for digoxin toxicity, especially for severe toxicity. You can use digibind. So the name of that antidote is called digibind. All right. So that's about digoxin toxicity. Now there is one question that sometimes can come to you. If a patient has got dilated cardiomyopathy, which means that their left heart or left ventricle is dilated, which means it cannot pump properly because it's not strong enough. In dilated cardiomyopathy, if you have got a patient with an ejection fraction less than 35%, that patient has an indication to get AICD. AICD is an automatic implantable cardioverter defibrillator. That means that this patient actually, they are very high risk to get a sudden cardiac death. So that's why you put that cardiac defibrillator. So in case their heart stop beating, this defibrillator will give a shock and heart will start beating again. So only indication for this AICD is if someone has got a dilated cardiomyopathy with the ejection fraction less than 35. All right. Now, we were discussing a little bit about pulmonary edema. Sometimes pulmonary edema can be a medical emergency because this can cause severe problem with breathing. The oxygen saturation can be severely low. So that's why sometimes if a patient with heart failure coming to you with an acute worsening of shortness of breath, think about possible pulmonary edema. And this patient can get into respiratory failure quite soon. So if you do an X-ray, you will get this kind of imaging on a pulmonary edema patient. You can see that bilateral increased vascular marking, and we call this as a bat wing appearance. If you look at here, this is called bat wing appearance of pulmonary edema. What are the features? So patient will have increased difficulty in breathing. Obviously, they will have tachypnea, so increased respiratory rate. Patient also can have bilateral or bibasilar crepitation in the lung, cough with a pink frothy sputum. Obviously, they will get orthopnea nocturnal dyspnea. So these are the finding of acute pulmonary edema. In acute pulmonary edema, you have to admit the patient, put the patient in propped up position, If oxygen saturation low, give oxygen and then start the patient with diuretics. So that's the main treatment, furosemide. You can also give morphine in this patient because that usually settles the anxiety patient actually got because of severe difficulty in breathing. You can give nitroglycerin to reduce the preload, which means reduce the blood volume that's coming to the heart. So that's pretty much the management of acute pulmonary edema. So you have to give a lot of furosemide to reduce the volume down. Okay. Any question with the heart failure guide? So that's actually the finishing of acute heart failure or congestive cardiac failure. Anything that you did not understand? All good? Moving on to valvular heart disease. In valvular heart disease, there is not much to go through from here. The only thing that comes in exam is the murmur. And you have to memorize the type of murmur and character of the murmur. It comes in exam so frequently. Now we have got the important murmur written in here, but I will show you an easy way to remember this. So if you look at here, you have to memorize at least one murmur. And by using that one murmur, you can remember most of the important murmur that come in exam. So look at the heart again. So we have got tricuspid valve between right atrium and right ventricle. We have got pulmonary valve in here. We have got mitral valve between left atrium and left ventricle. And also we have got aortic valve in the left ventricle, right? So these are the main valves that we normally need to know about. But which one is important? Mitral and aortic. Pulmonary and tricuspid does not come in exam, so don't bother too much with it. Now the murmur means that there is increased blood flow through this valve. Either there might be a narrowing of this valve, which we call a stenosis, or the valve might not work properly and blood can regurgitate back to the original place. And that is what we call regurgitation. So mitral valve, it can have mitral stenosis, mitral regurgitation. Aortic valve can have aortic stenosis, aortic regurgitation. Now, we can remember only mitral stenosis. So if you remember mitral stenosis murmur, this is a mid-diastolic murmur. And mitral murmur, you will always feel at the apex bit, which is your left fifth intercostal space. Okay. Before we go to the other thing, the place of your murmur is also important to know. So if this is your sternum, that's the left side and this is the right side. This is your intercostal space 2, 3, 4, 5. Okay. Now, at the left, this is left fifth intercostal space. You will get mitral murmur. At the left second intercostal space, usually along the sternal edge, like over here, you will get pulmonary murmur, because see the positioning of the pulmonary valve, it comes to the left from the right. So that's why you will get left second is for pulmonary, and see the aorta, it's come from here to the right. So usually aortic one you will get in the right second intercostal space. Kind of tricky, right? And then in the left fourth intercostal space, you will get tricuspid murmur. Okay, so these are the usual murmur site. There are differences which we will discuss later on, but this is the usual site of murmur. So mitral murmur is in the left fifth intercostal space. Left fourth intercostal space is for tricuspid. Left second is for pulmonary. Right second is for aortic murmur. Now come to the murmur again. So mitral stenosis gives you a mid-diastolic murmur in the left fifth intercostal space. Always remember that the opposite of mitral stenosis will also be diastolic murmur. So what is the opposite of mitral? Aortic. So remember that, like opposite of mitral is aortic and opposite of systole is diastole. Sorry, opposite of stenosis is regurgitation. So opposite of mitral is aortic, opposite of stenosis is regurgitation. So aortic regurgitation will also have a diastolic murmur. But what kind of diastolic murmur? Early diastolic murmur. An aortic regurgitation murmur, now this murmur usually you will not get in the right second intercostal space. Rather, it usually best feel in the left fourth intercostal space. So this is actually a little bit unusual one, but you have to just remember it. Okay. After that, think about what is left. So we have done MS. So the other part of MS is mitral regurgitation. And we have aortic regurgitation. So what is left in the aortic? Aortic stenosis. Right? Now these two will be systolic blood pressure, systolic murmur. So mitral regurgitation murmur will be pan-systolic murmur, and mitral means it will be on the left fifth intercostal space. And this mitral regurgitation murmur can radiate to axilla. So that's the important finding. And then we have aortic stenosis, which gives you a ejection systolic murmur. And that murmur will be in the right second intercostal space. And this murmur can radiate to your neck or carotid area. So these two murmur, like systolic murmurs, they radiate. So see that if I can only remember mitral stenosis, I can actually remember all these four. I don't even need to memorize any of this. It just comes with practice. So if you have mitral stenosis murmur in your head, which is the mid-diastolic murmur, so you can easily find out that what is the opposite of MS? Aortic regurgitation. So that is also a diastolic murmur, but it's an early diastolic murmur. So what is left in the mitral and aortic area? Left is mitral regurgitation and aortic stenosis. So those are systolic murmur. At least by this, you can easily exclude a lot of options as well. Okay, is this understandable, guys? I feel like you should understand this one and you can remember it, and it is so easy just to exclude a lot of options using this thing. because you can't get any mnemonic to remember all this murmur. So you have to have something in your head so that in case you get confused in your exam, you can use this. Okay, so if we go through it a little bit, so we have got mitral stenosis murmur, which is a mid-diastolic murmur, and it's actually, we call it like a low-paced rumbling murmur, and it is mainly found in the left intercostal space, which is the left fifth intercostal space. Aortic regurgitation is a high-pitched early diastolic murmur. Then we have got mitral regurgitation, which is a hollow systolic or pansystolic murmur. And aortic stenosis, it's an ejection systolic murmur. There is also very good these murmurs in med bullets. So if you go here, you can see that aortic regurgitation, they have explained it here. Mitral valve stenosis, they have explained it here. So a lot of common one they have already explained. And they have also written like the findings of murmur in here. So you can go through this as well. All right, so that's all about the murmur that you need to know. There is not much you need to know from here apart from the murmur type, character, and the site. Okay, any question? All right, so let's take a 5-minute break, and after that, we will discuss more cardiologies. We will start with cardiomyopathy. Okay. All right, everyone, let's start again. You guys are enjoying the session? Is there anything that you guys are not understanding? These are actually very, very complicated if you don't understand it. So I'm going a little slow today. Once you understand the topic, then I will just be very fast. Okay. Moving on to cardiomyopathies. So we have got three kinds of cardiomyopathy. Cardiomyopathy means the cardiac muscle problem. The dilated cardiomyopathy, it means that patient, the ventricle muscle has become weaker or dilated. So obviously, if there is dilation of the cardiac muscle, so if you look at here, so this is usually the normal cardiac muscle or the left ventricular muscle, which has thickness, and that's the strength of it. But if you look at here, the thickness has been reduced, and now it's more dilated. When it becomes more dilated like this, it can't contract like before. And that is what we call as dilated cardiomyopathy. So my question is that if you have got a dilated cardiomyopathy, what kind of heart failure will you get? Systolic or diastolic? Yeah, systolic, right? Because that's the thing, like contractility. If contractility is not good, that means systole is not good. That's the basic you have to understand first. That means obviously if the heart muscle is dilated, it can't contract well. If contraction is the main issue, that means systole is not happening. If systole is impaired, that means it's a systolic heart failure. Okay, so dilated cardiomyopathy, it will give you systolic heart failure. The most common cause is idiopathic, that means not known. Other than that, the alcohol can cause it, some viral infection, toxicity, some drug can also cause it. The features will be heart failure features. Treatment, the same treatment that you give for systolic heart failure, like ACE inhibitor, beta blocker, spironolactone, furosemide, that's the treatment for dilated cardiomyopathy. Then there is another cardiomyopathy, which is pretty important for your exam. That is what we call as HOOCM, or hypertrophic obstructive cardiomyopathy. So HOCM, sometimes it can be hereditary in 60% cases, which is autosomal dominant in nature. The main feature of this cardiomyopathy is that the myocardium, especially the interventricular septum, get thickened. If you look at the picture, this is the interventricular septum between two ventricles. And now look at the hypertrophic one. So in hypertrophic cardiomyopathy, the muscle will become thick, and also the ventricular septum will become thicker like this. Now, as you can see that there is obviously a small space left for left ventricle. So what kind of heart failure you will find in HOCM patient? Systolic or diastolic? Diastolic, right? Very good, because now the heart cannot relax because it's very thick. So then you get a diastolic heart failure. And obviously, as a result of the hypertrophy, sometimes you can see that it can also block the cardiac compliance, right? So left ventricular compliance will be reduced, or space will be reduced, but systolic performance will be fine. Now, obviously, the heart muscle is very thick and very strong, and it has to pump a little amount of blood, and it will be more than normal. So ejection fraction in this patient sometimes even reaches 80 to 90%. So that's one of the other features. So see that often ejection fraction are 80 to 90% in this case. The features will be same like heart failure features. So patient will come to you with dyspnea, sometimes chest pain, pre-syncope, syncope. You can also get a S4 gallop rhythm. You can get bifid carotid pulse. In this patient, you can get systolic murmur as well as mitral regurgitation murmur. The systolic murmur you get in HOCM is same like aortic stenosis murmur, which is your ejection systolic murmur. So ejection systolic murmur is the main murmur for HOCM also. But the murmur is best heard in the left fourth intercostal space. Mitral regurgitation murmur can also happen in this patient. That means you can also get a pansystolic murmur. Okay. Why it is like that? Because if you see here, that's the mitral valve. Because of this hypertrophied septum, it can actually make this valve weaker, leading to mitral regurgitation. So you can get two kinds of murmur in this patient. If you do the ECG in this patient, you might get left ventricular hypertrophy features. And echocardiogram is the mainstay of diagnosis. Now, question comes with a lot of things. One of the things is that what is your most appropriate investigation in this patient? That is echocardiogram. What is the next most appropriate investigation? That's ECG. So always you will start with ECG before doing an echocardiogram. Now let's say resting echocardiogram is normal, but you are suspicious that it can be HOCM. Then your next approach would be to do a stress echocardiogram. Sometimes when you do the stress echocardiogram, then it might become more evident that this ventricle will become more active, and then you can find it in the echocardiogram. So a stress echocardiogram will be your last option if resting echo is normal. What is the treatment? Because this is a diastolic heart failure, your main treatment will be calcium channel blocker or beta blocker. See that this is how we remember. Otherwise, you had to memorize everything. Now you don't need to do that. And in case of severe cases, you might need to do the surgery like cutting the septum into normal, or septoplasty can be done. Okay, so that's your HOCM. The last cardiomyopathy is restricted cardiomyopathy, which is not very common, but it's the most dangerous one. In this cardiomyopathy, the ventricular wall becomes rigid and it doesn't move at all. So that is called rigid, non-compliant ventricular wall. If the myocardium becomes rigid, obviously ventricular feeling will not be there. So there will be diastolic dysfunction. Again, if the myocardium is not moving, systolic function will be also reduced. So this patient actually get both systolic and diastolic heart failure. Okay. And features of heart failure will be there also. There is no specific treatment, and usually patients die from heart failure or arrhythmia. The only option is doing a heart transplantation. Okay, next, moving on to some other cardiac condition, acute pericarditis. Very important topic for the exam. Remember in Cardiology 1, when we did the chest pain, we discussed about pericarditis. So acute pericarditis is the inflammation of the outer layer of the heart, known as pericardium. And the patient comes to you with a sudden onset of chest pain, which most likely substernal, or sometimes even left side of the chest, which get worse with lying down, coughing, and deep breathing, and gets better with sitting up and leaning forward. Sometimes you will also get a history of recent viral flu-like illness. If you do auscultation, you can get pericardial friction rub, which is diagnostic of pericarditis. What are the causes of acute pericarditis? Idiopathic, then viral infection, sometimes some of the connective tissue disease like SLE, sometimes disorder of metabolism, like if you have got uremia because of renal failure, then you can get uremic pericarditis. Okay, so those are mainly the causes of acute pericarditis. In terms of investigation, ECG is the diagnostic test, but if you want to confirm or if you want to check for any pericardial effusion, you can do a echocardiogram also. Treatment based on the etiology, but mainly for pain, you can give them Panadol and anti-inflammatories like NSAID. Sometimes if NSAID is not helpful, you can either give some steroid or even colchicine. Moving on to pericardial effusion, which means there is collection of fluid in the pericardial cavity now. So if this is your heart, this is the pericardium, the outer covering. Normally, there should not be any fluid in this cavity, but when there is accumulation of fluid due to some reason, that is what we call as pericardial effusion. Now, it can be due to a lot of causes, especially if patient has got heart failure that can cause it. Sometimes hypoproteinemia can cause it. Some infection like tuberculosis, some cancer can cause it. Even if patient has got penetrating trauma to the pericardium or heart, that can cause it. If you want to confirm the diagnosis, then you have to do an echocardiogram, and that's the only way to find out. The treatment is aspirate the fluid through through pericardiocentesis. Now, pericardial effusion is not very important, but the important one is cardiac tamponade. We will come to that, but look at this chest X-ray. See that how big the heart looks like. This usually you get in pericardial effusion. So like it looks like a water bottle. And that's what you get in pericardial effusion patient. Cardiac tamponade, in the other hand, it's a life-threatening condition in which pericardial effusion has developed so rapidly or has become so large that now it's compressing the heart. Now, when it compresses the heart, what happens? Heart can't move. That means heart can't get relaxed, right? That if there is a lot of fluid around you, you will not be able to relax. You will not be able to dilate. So if you can't dilate or if your heart is not able to relax, the blood cannot come in to the heart, right? So you also get features of heart failure in this patient. Patient complain of dyspnea and orthopnea. Patient in this condition, the finding you will get, obviously, if heart is not feeling, then what will happen? The vena cava, all of this will be engorged. So you'll get neck distension or raised GVP. The patient will have muffled heart sound because if there is fluid around the heartbeat will be very muffled. So there is a triad of acute tamponade that we get called Beck's triad. You get hypotension, you get distended neck vein, and you get muffled or decreased heart sound. So hypotension, muffled heart sound, and raised JVP, that's cardiac tamponade. If you do the echocardiogram, you will confirm the diagnosis, and once confirmed, you have to go for immediate pericardiocentesis to drain that fluid out. Okay, so that's cardiac tamponade. The next is constrictive pericarditis. Now, this is not quite commonly asked in the exam, but remember one thing, that constrictive pericarditis means the pericardium has got diffuse thickening, usually in response to some previous inflammation, If it is diffusely thick, so again, if this is the heart and that's the pericardium, obviously when your heart is relaxed or getting dilated, the pericardium also relaxing. But if your pericardium or outside layer is very stiff or thickened, what will happen? Heart will not be able to distend properly. And again, you might get a diastolic failure in this patient. Okay, so the features of diastolic heart failure, like any of the heart failure features, will be there. And sometimes if you do an X-ray test, you can get an eggshell appearance. This is actually the calcification of pericardium. Looks like an eggshell appearance. Okay, and that is the finding of constrictive pericarditis. All right, so that's pretty much everything that you need to know in some of the other causes of cardiology topics. So these topics does not fall into any specific thing, but this is important, especially pericarditis, cardiac tamponade. This comes in exam. Any questions so far, guys? If not, then we will start with hypertension. Now, hypertension, you have a chapter in John Murtagh, in Murtagh 8th edition. Let me just try to find out. So chapter 77 in John Murtagh 8th edition. That's what you get, all of it. Okay, and if you have 7th edition, that's your 86. So chapter 86 is mainly for 7th edition. And we have 77, that's for 8th edition. Now coming to hypertension, this is our last topic for cardiology tonight. So hypertension, it's a very common thing. All of you already know it, but it's still, if I ask you a few questions, you will be wrong, because these are very commonly discussed topic, but still it is not very clear for many candidates. So normally we measure blood pressure from 18 years of age in Australia. For 18 years and older, hypertension means that if systolic pressure more than 140 or diastolic pressure more than 90, that is hypertension. Okay. Optimal pressure is less than 120 by 80. Normal, we keep it like 120 to 129. Like you just remember that high normal is up to 130 by 90. Or so once it become more than 140 by 90, that's hypertension. So up to 139 by 89, that's normal. So hypertension has divided into grade 1, 2, and 3 based on this systolic and diastolic blood pressure. So if systolic is up to 159 and diastolic 99, that's a grade 1. 160 to 179 by 100 to 109 diastolic, that's grade 2. And more than 180 by 110, that's grade 3. Now you don't need to remember all of it, but at least know that what is hypertension. And if you can, just remember the mild, moderate, and severe values. Causes of hypertension. About 90 to 95% cases, there is no cause of hypertension. And that is what we call as essential hypertension. But in other 5 to 10%, There is a lot of causes that can cause hypertension. So kidney related, like glomerulonephritis, reflux nephropathy, renal artery stenosis, very important. Then endocrine related, primary aldosteronism, like Conn's syndrome, Cushing syndrome, pheochromocytoma, even oral contraceptive can cause it. Coarctation of aorta, some of the drug like NSAID steroid can also increase blood pressure. Okay, so these are the secondary causes of hypertension. You don't need to memorize that. Just try to remember the important ones. What are the clinical features that suggest secondary causes of hypertension? So if you have got a patient with hypertension and also have got renal artery bruit, so if you get a bruit in the renal artery, that's most likely renal artery stenosis. Hypertensive patient having hematuria, RBC cast, and proteinuria, that's glomerulonephritis. Bilateral kidney mass with a family history of kidney problem, that's polycystic kidney disease. Radiofemoral delay, coarctation of aorta. Patient having obesity, snoring at night, daytime sleepiness, then most likely obstructive sleep apnea. So these are actually the features that would suggest that this patient might have got something else, like there is something underlying which causing this hypertension. What is malignant hypertension? If a patient has got diastolic pressure more than 120, and also they have got retinopathy and kidney failure, that is malignant hypertension. What is refractory hypertension? If the blood pressure is still high, despite giving maximum dose of 2 drugs for 3 to 4 months. So if you have given maximum 2 drugs, but still patient has got high blood pressure, that is refractory hypertension. Now, renal artery stenosis, it's important to remember as one of the cause of secondary hypertension. Renal artery stenosis usually occurs by some fatty deposition in the kidney artery, which means someone who has got atherosclerotic problem like ischemic heart disease, peripheral vascular disease, high cholesterol, they are more prone to get this kind of problem. A young girl has got hypertension, and you can get a renal bruit on their abdomen. That's most likely due to another condition called fibromuscular dysplasia. Whatever is the cause is, if you want to confirm the diagnosis, you have to do a Doppler duplex ultrasound of the renal artery. That is the investigation of choice. For renal artery stenosis, what is your initial treatment? If you want to treat a patient with renal artery stenosis, especially you want to control blood pressure, which one is your preferred antihypertensive? Your preferred antihypertensive is ACE inhibitor or ARB. Only if it is a unilateral renal artery stenosis. If it is a bilateral renal artery stenosis, then you can't use any of these. Then your best antihypertensive will be calcium channel blocker. Okay? So that's actually your renal artery stenosis management. Now let's say you have got a patient with hypertension. The first visit you have got it. Can you confirm the diagnosis? No. So you can't confirm hypertension on the basis of a single visit. Initial raised BP recording should be confirmed on at least 2 other visits within a space of 3 months. And if still it is high, then you can say that it is a hypertension. What is the recommended screening of blood pressure in normal population? Everyone aged 18 years and over, at least every 2 yearly, should check their blood pressure. This comes in exam, so remember it. Now come to the follow-up criteria for a patient who you recently diagnosed as hypertension. If you have got a patient with a normal blood pressure, but not optimal, then you can recheck in 1 year time. Especially high normal, this is the high normal one. So if you've got a high normal patient, then recheck in 1 year and advise some lifestyle modification. If it is grade 1 hypertension, then confirm that this patient actually has got hypertension, do another blood pressure check in 2 months, and just do a lifestyle modification. When grade 2, check the patient again in a month with lifestyle advice. If it is grade 3, either you can evaluate the patient in 1 week time, or you can also start medication immediately. So if it is not grade 3, you don't just start the medication immediately. Okay, you at least wait for either months, like 1 month for grade 2, 2 months for grade 1. Okay. So if mild hypertension is found, observation with repeated measurement over 3 to 6 months should be followed before beginning therapy. If a patient's initial diastolic pressure more than 115 and they have target organ damage, like if they have got kidney problem, if they have got vision problem because of hypertensive retinopathy, then they need immediate treatment. Now, there is a term that we use called ambulatory 24-hour blood pressure monitoring. This is one of the important diagnostic feature for someone who has borderline hypertension or who are having fluctuating level of hypertension. That means at one visit, you have got blood pressure 120 by 80. Next visit, you have got 150 by 80. Another visit, you have got 180 by 110. So there is a lot of discrepancy in each visit. That is one of the time where you can do this ambulatory 24-hour blood pressure monitoring. Remember, this is not same as Holter monitoring. In ambulatory BP monitoring, only thing that you check is the blood pressure. But in Holter monitoring, you are checking the heart rhythm mainly. So it's different. So what is the indication for ambulatory BP measurement? If there is unusual variability in the office blood pressure, marked discrepancy between home and office BP, refractory hypertension, suspected sleep apnea patient. This patient usually will go for an ambulatory BP monitoring. Now, initial management of hypertension begins with lifestyle modification, especially for mild hypertension. 3 months of lifestyle modification is the choice of management. Okay. And the lifestyle management, the most important one is weight reduction. If a patient lose at least even 1 kilo body weight, their blood pressure will drop by 2.5 millimeter mercury. Okay. Then reduction of alcohol intake, reduction of salt intake is also important. Then there is also some other things which like a smoking, management of sleep apnea, doing some exercise, all are important lifestyle modification. There is one other thing. When you get a patient, on several occasions, they have hypertension. That means you now diagnose that patient with hypertension. You start lifestyle changes, but at the same time, you also assess their 5-yearly cardiovascular risk. Remember that one that we have done? Like you have to find out if this patient is a low risk, moderate risk, or high risk. Based on that, your management will be different. If it's a low risk patient, then you can even try lifestyle modification for a year. Okay. And even after that, even after doing lifestyle modification, blood pressure is still higher than 150, then you can start treatment. For moderate risk, lifestyle for 3 to 6 months, and even after 3 to 6 months, blood pressure higher than 140/90, then start treatment. For high-risk patient, you can even begin treatment immediately. Okay, so that's actually the importance of doing the cardiovascular risk. When you start medication, you have mainly three choices. One is ACE inhibitor or ARB. You have calcium channel blocker and thiazide diuretics. These are your three main antihypertensive that you can use. Especially thiazide diuretic is important if patient is more than 65 years of old. And ARB is mainly for more younger population. Okay. Let's say you started any of these medication. If the target not reached after 3 months, then you can combine ACE inhibitor with calcium channel blocker. You can combine ACE with thiazide or H with beta blocker. Any of this combination is fine. Even after that, target not reached, then three medication combination, ACE inhibitor, calcium channel blocker, and thiazide will be your choice. Even after that, there is no improvement, then you can use a spironolactone or seek a specialist advice. Okay, so that's actually the management of hypertension. A relatively ineffective combination is if, like normally, if you just give ACE and beta blocker, it's not a good combination. Same calcium channel and diuretic, not very good combination. The best combination is ACE inhibitor with calcium channel blocker. And never give like beta blocker and verapamil in the same patient, because beta blocker will lower the heart rate and verapamil also will do the same. And patient can end up getting a heart block or heart failure. Same if you use ACE inhibitor and spironolactone, you can get a massive hyperkalemia. Patient can get cardiac arrhythmia and even death. What is hypertensive emergency? Hypertensive emergency means that when blood pressure is so high that patient came to you with complication like hypertensive encephalopathy. So patient with hypertension now very confused, altered mental status, or patient having stroke, heart failure. These are the hypertensive emergencies. You have to refer this patient to emergency department immediately for further monitoring and treatment. But you can't lower down the blood pressure too much at one point. Just aim that you will not reduce blood pressure not more than 25% within the first 2 hours. So gradual decrease of blood pressure, which normally you can get by either using a calcium channel blocker or ACE inhibitor. Okay. Now, this is the most important chart, which comes in exam in many ways. So, choice of antihypertensive based on a patient medical comorbidities. That means you can't use every antihypertensive to every patient. Like, let's say you have got a patient with asthma or COPD. In that patient, you can't use beta blocker because it can cause bronchospasm, but all others are fine. For a patient who has got bradycardia or heart block, we can't use beta blocker, and also we will not use calcium channel blocker because that can cause more bradycardia. For cardiac failure, if it's a stable cardiac failure, you can use beta blocker, but normally for cardiac failure patient, we don't use calcium channel blocker unless it is a diastolic heart failure. The best medication for cardiac failure will be ACE inhibitor and diuretic, especially for systolic heart failure. Patient, we will not use diuretics, but the best will be ACE inhibitor or ARB. Same for dyslipidemia, high-jet diuretics is not a good choice. For gout or hyperuricemia, high-jet diuretics is not a good choice. Good choice is ACE inhibitor or calcium channel blocker. If a patient has got peripheral vascular disease, you should not use beta blocker because it can again cause vasospasm. What will be the best treatment? Calcium channel blocker, because it can cause vasodilation. Then it will be more beneficial for a peripheral vascular disease patient. Same with Raynaud phenomenon. Best medication will be calcium channel blocker. We already know renal artery stenosis. Now in here they have written cross, but for unilateral renal artery stenosis, ACE inhibitor is our choice. For bilateral, calcium channel blocker is the choice. For kidney failure patient, you can use diuretic, you can use calcium channel blocker, but you have to be careful with ACE inhibitor. You can use ACE inhibitor, but if the patient having stage 3 or more kidney failure, then you can't use ACE inhibitor anymore. Okay, so that's actually you have to remember from here because it comes in many ways in exam. Now there is one chapter that we haven't discussed. That is the chapter 70 in JM 8th edition, palpitation. As I said, that palpitation will be covered with our ECG class because both of them are similar kind of thing. So we will discuss, let's say, atrial fibrillation. At that time, we will discuss what is atrial fibrillation and what is the management of it. Okay, so we just keep this palpitation for our ECG class. Any question, guys? So that brings us to the finishing of tonight's session. Do you guys have any question about the course? You can unmute yourself because that's fine. Our class is over now. So if you want to talk and unmute yourself, that's also okay. All good then. So we'll see you again tomorrow. Now, tomorrow class will be question solvation. That means we will solve some cardiology question. So try to join the class as well because that's the most important class out of everything. And you will know that how your theory knowledge helps with some question solvation. Okay. All right then. So we will finish it here tonight. Have a good night. Bye.